There are 5 pills sitting in medicine cabinets across the world right now. Some of them require a prescription. Some of them you can buy without one. Off the shelf, any pharmacy, no questions asked. Many seniors take at least 2 of them every single day. Some take all 5. And every single one of them, taken regularly, without adequate monitoring, without the specific precautions that aging kidneys require, is doing measurable, documented damage to the most overlooked filtration system in the human body. I want to be clear about something before we go any further. These medications were prescribed or purchased for real reasons, real conditions, real pain, real needs. The physicians who prescribed them, in most cases, made reasonable decisions with the information available at that appointment. But here is what most patients are never told. The aging kidney processes medication differently, fundamentally biologically differently. And a drug that was safe and appropriate at 55 can become a genuine nephrotoxic threat at 70, without anyone changing the dose, without anyone issuing a new warning, without any signal at all until a blood test reveals a number that changes everything. That blood test, and that conversation, should be happening now, before the number changes. And that is exactly what this video is for. Before the 5 pills, I need to give you the physiological foundation, because without this, the risks I'm about to describe will feel abstract rather than urgent. 3 things happen to the kidney after 60 that collectively transform the nephrotoxicity risk of common medications. First, GFR declines. Glomerular filtration rate, the measure of how efficiently the kidneys filter blood, decreases by approximately 1 milliliter per minute per year after age 40. By 70, the average person has lost 30 to 40% of their peak kidney filtration capacity. This is considered normal aging, not disease. But it means that medications cleared by the kidneys accumulate to higher blood concentrations on the same dose, because the clearance system is operating at reduced capacity. Second, renal blood flow decreases. The volume of blood flowing through the kidneys per minute falls by approximately 50% between ages 30 and 80. This reduced blood flow makes the kidneys far more vulnerable to any further reduction, caused by dehydration, low blood pressure, or medications that constrict renal vessels. What was a tolerable hemodynamic stress at 45 becomes dangerous renal ischemia at 72. Third, tubular regenerative capacity declines. The proximal tubule cells, which do the heavy lifting of kidney filtration, have limited ability to regenerate after injury at any age. That capacity diminishes further with aging. Damage that would have recovered completely in a younger kidney may become permanent in an aging one. These 3 changes together mean that the same pill, at the same dose, prescribed by the same doctor, produces a meaningfully different and more dangerous pharmacological environment in a 70-year-old kidney than in a 50-year-old kidney. With that understood, here are the 5 pills. Pill number 1, the pain reliever that poisons, NSAIDs, ibuprofen, naproxen, diclofenac. Let me start with the most important, because this one is available without a prescription, because millions of seniors take it daily, and because it is responsible for more preventable kidney damage in older adults than almost any other single pharmaceutical agent. NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen sold as Advil, Motrin. Naproxen sold as Aleve, diclofenac, indomethacin, celecoxib, the most widely used class of pain medication on Earth. Here is the precise mechanism by which NSAIDs damage aging kidneys. Your kidneys depend on compounds called prostaglandins, specifically prostaglandin E2 and prostacyclin, to maintain adequate blood flow to their filtration units. Prostaglandins keep the afferent arterioles, the blood vessels feeding the glomeruli, dilated and open. They are the kidney's own blood flow regulation system. NSAIDs work by inhibiting COX enzymes, cyclooxygenase 1 and cyclooxygenase 2, the enzymes responsible for prostaglandin synthesis throughout the body. That inhibition is how they reduce pain and inflammation. But inside the kidney, blocking prostaglandin synthesis withdraws the very signal keeping the renal blood vessels open. Afferent arterioles constrict. Blood flow to the glomeruli falls. The kidney experiences ischemia, oxygen and nutrient deprivation, at the cellular level. In a healthy young kidney with abundant renal reserve and strong hemodynamic compensation, this effect is transient and manageable. In an aging kidney already operating at 60% of peak capacity, with reduced renal blood flow and limited compensatory reserve, NSAID-induced renal ischemia can precipitate acute kidney injury from a single recommended dose, particularly in the context of mild dehydration. A study published in JAMA Internal Medicine found that regular NSAID use, defined as more than 15 days per month, was associated with a twofold increase in the risk of chronic kidney disease progression in adults over 65. A second study from Johns Hopkins found that daily NSAID users had a significantly higher rate of acute kidney injury episodes requiring hospitalization compared to non-users, with the risk dramatically amplified in those who were even mildly dehydrated. The World Health Organization and the American College of Rheumatology both specifically identify NSAIDs as medications requiring extreme caution or avoidance in adults with reduced kidney function. The question to bring to your doctor: I'm currently using ibuprofen or naproxen regularly for pain management. Given my age and kidney function, is this still appropriate? And what alternatives? Acetaminophen, topical anti-inflammatories, physical therapy, newer targeted agents, could reduce or eliminate my need for systemic NSAIDs. Never take NSAIDs daily without explicit physician guidance that accounts for your current GFR. Your kidneys cannot indefinitely absorb the hemodynamic cost. Pill number 2, the blood pressure paradox. ACE inhibitors and ARBs in specific conditions. This one requires the most careful nuance of anything on this list. Because ACE inhibitors and ARBs, angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, are actually kidney protective medications in many contexts. They are first-line treatment for diabetic kidney disease precisely because they reduce the pressure inside glomeruli and slow the progression of proteinuria-driven damage. I am not telling you to stop your lisinopril. I am telling you about the specific conditions under which these medications, which are broadly beneficial, can become acutely nephrotoxic in aging kidneys. Conditions that are common, under-recognized, and that every senior taking these drugs should know by name. The mechanism. ACE inhibitors and ARBs lower blood pressure by blocking the renin-angiotensin-aldosterone system, the hormonal cascade that regulates renal blood flow and sodium balance. One specific component of this system, angiotensin II, constricts the efferent arteriole, the blood vessel leaving the glomerulus. This constriction maintains adequate filtration pressure inside the glomerulus. When ACE inhibitors or ARBs block this system, the efferent arteriole relaxes, filtration pressure inside the glomerulus falls. In most patients, this is the intended and beneficial effect. But in two specific situations, it becomes dangerous. First, bilateral renal artery stenosis. When both renal arteries are narrowed, which is common in older adults with atherosclerosis, the kidney is already dependent on angiotensin II to maintain filtration pressure against the upstream resistance. Blocking angiotensin II in this context can precipitate acute kidney failure. This condition is often undiagnosed. Second, acute volume depletion. When an older adult on an ACE inhibitor or ARB becomes dehydrated, from vomiting, diarrhea, excessive heat, inadequate fluid intake, the combination of reduced volume and blocked angiotensin II compensation can cause abrupt, severe reduction in GFR. This is the scenario described in nephrology as the triple whammy: ACE inhibitor plus diuretic plus NSAID in a dehydrated patient, one of the most reliable recipes for acute kidney failure in geriatric medicine. A study published in the British Medical Journal found that the combination of an ACE inhibitor or ARB, a diuretic, and an NSAID in older adults was associated with a threefold increase in acute kidney injury requiring hospitalization. 3 commonly prescribed medications, each individually appropriate, combining to create a kidney emergency. The question for your doctor: I'm on an ACE inhibitor or ARB. What should I do during an illness with vomiting or diarrhea? Should I temporarily hold this medication? And have I ever been evaluated for renal artery stenosis? These are the conversations that prevent the emergency department visit. Let me stop here for a moment, because I want to acknowledge something directly. The 5 pills in this video were not prescribed carelessly. Most of them were prescribed appropriately, for real conditions, by physicians working within the constraints of brief appointments and complex patient histories. The problem is not bad medicine. The problem is incomplete information, information that doesn't get updated as the patient ages, as the kidney function changes, as the medication list grows longer. And into that information gap, that space between the prescription written 5 years ago and the biology of the kidney today, steps an industry selling kidney support supplements and renal protection formulas that have no peer-reviewed evidence of benefit and some documented evidence of harm. The answer to medication-related kidney risk is not a supplement. It is a conversation. An informed, specific, age-appropriate conversation with your physician that uses the questions this video is equipping you to ask. If you believe that every senior taking daily medications deserves access to this kind of honest, clinical information about what those medications are doing to their kidneys, comment below and say, "I deserve the truth." Because you do. And so does every person you love who is taking medications prescribed years ago without a kidney-specific review since. Pill number 3, the antibiotic aftermath, aminoglycosides and certain antibiotics. Most seniors don't take aminoglycoside antibiotics, gentamicin, tobramycin, amikacin, regularly. These are typically administered intravenously in hospital settings for serious infections. So why are they on this list? Because when they are administered, and for older adults hospitalized with pneumonia, urinary tract infections, or sepsis, they sometimes are, the risk of permanent kidney damage in the aging patient is dramatically higher than most families and patients understand. And that risk directly affects the monitoring and advocacy decisions you can make. Aminoglycosides are directly tubulotoxic. They destroy the proximal tubule cells of the kidney through a specific mechanism involving drug accumulation inside the tubular epithelium. The drug enters the tubule cells through specific transport proteins, accumulates in lysosomes, the cell's waste processing organelles, and triggers a cascade of oxidative injury that kills the cell. In younger patients with strong regenerative capacity, this damage often recovers. In older adults with declining tubular cell regeneration, it may not. A study from the Journal of the American Geriatric Society found that aminoglycoside-related nephrotoxicity occurred in up to 25% of elderly patients receiving these antibiotics, compared to approximately 10% of younger patients, even with careful dosing and monitoring. But there is a second antibiotic category that is relevant for outpatient seniors. Certain fluoroquinolones, specifically high-dose ciprofloxacin and levofloxacin, which have been associated in pharmacovigilance studies with acute interstitial nephritis, an immune-mediated inflammation of kidney tissue in susceptible individuals. The practical action: if you or a loved one is hospitalized and aminoglycoside antibiotics are proposed, ask specifically, is this the only effective option for this infection? What alternatives exist that carry lower kidney risk? And if aminoglycosides are necessary, what is the monitoring protocol for kidney function during and after treatment? Advocate for daily creatinine monitoring during aminoglycoside treatment. You are entitled to that monitoring. And in older adults, it is essential. Pill number 4, the contrast catastrophe, iodinated contrast dye. This pill is not a pill in the traditional sense, but it enters the body as a pharmaceutical agent during a medical procedure. And for seniors with reduced kidney function, it is one of the most acutely dangerous nephrotoxic exposures in clinical medicine. Iodinated contrast dye is used in CT scans with contrast, coronary angiography, and certain other imaging procedures. It allows blood vessels and tissues to be visible on imaging. It is an enormously valuable diagnostic tool, and in patients with normal kidney function, it is generally well tolerated. In patients with reduced GFR, which, as I established, describes a significant proportion of adults over 65, even without a formal CKD diagnosis, iodinated contrast can trigger contrast-induced nephropathy, CIN. The mechanism involves direct tubular toxicity from the contrast medium, combined with renal vasoconstriction that reduces blood flow to the medulla, the innermost region of the kidney, causing ischemic injury to the tubular cells in that region. A study published in Radiology found that contrast-induced nephropathy occurred in approximately 14% of patients with pre-existing kidney disease undergoing contrast-enhanced procedures, with a significant subset developing permanent GFR decline. Here is what you can and should advocate for if a contrast CT or angiogram is recommended. First, ask whether a non-contrast imaging study would provide adequate diagnostic information. Second, if contrast is necessary, ask whether you will receive IV hydration before and after the procedure. This is the most effective protective measure available and is standard of care in patients with known kidney disease, but sometimes overlooked in those with borderline function. Third, ensure your most recent creatinine and GFR are available to the radiology team before the procedure. This is essential for dose adjustment decisions. These are not difficult questions. They are appropriate clinical advocacy. And in an aging patient with a GFR of 55 or 60, which looks almost normal on a report, the contrast risk is real and deserves this precaution. Pill number 5, the supplement shock, herbal and over-the-counter pills that destroy nephrons. This final category encompasses the products sold most aggressively to seniors concerned about their health, and it contains some of the most potent nephrotoxins available without a prescription. The herbal and supplement industry operates under dramatically different regulatory standards than pharmaceuticals. Supplements do not require proof of safety or efficacy before reaching the market. They are not required to disclose all active compounds, and when they cause harm, as documented in hundreds of peer-reviewed case reports, the connection between the product and the kidney damage is often identified only retrospectively, after the patient has already lost function. The most dangerous nephrotoxic supplements documented in the medical literature include aristolochic acid, found in certain traditional herbal preparations used in some Asian traditional medicine systems, sometimes present as an adulterant in other herbal products without disclosure. Aristolochic acid causes a specific and devastating form of kidney damage called aristolochic acid nephropathy, progressive destruction of proximal tubule cells leading to kidney failure, and markedly increased risk of urothelial cancer. It has caused kidney failure and death in documented cases worldwide. The FDA has issued warnings, but supplements containing it still reach consumers through unregulated supply chains. High-dose vitamin C supplements, as I've described in previous videos, doses of 1,000 milligrams or more daily significantly increase urinary oxalate, doubling kidney stone risk in susceptible individuals. A study in JAMA Internal Medicine confirmed this association specifically in men taking high-dose supplemental vitamin C. Chromium picolinate, marketed for blood sugar management, has been associated in case reports with acute tubular necrosis, direct tubular cell death, at doses commonly found in commercial supplements. Creatine supplements, popular in older adults attempting to preserve muscle mass, artificially elevate serum creatinine, which is used to calculate GFR. This can mask early kidney function decline by obscuring the creatinine rise that would otherwise signal a problem. A patient supplementing with creatine may appear to have stable GFR when actual filtration capacity is declining. Thunder God Vine, a traditional herbal compound, has documented nephrotoxicity in clinical case series, causing acute kidney injury in multiple reported patients. A systematic review published in the American Journal of Kidney Diseases found that herbal and dietary supplement use was responsible for a significant and growing proportion of acute kidney injury cases, with older adults disproportionately represented due to their higher supplement consumption rates and reduced renal reserve. The practical action: bring every supplement, every capsule, powder, and herbal product to your next physician appointment. Not just your prescription medications, everything. Ask your doctor to review each one against your current kidney function, and approach any product marketed as a kidney cleanse, renal support, or detox formula with particular skepticism. These are precisely the products most associated with documented kidney harm. I want to close with something I want you to carry out of this video. The medications on this list are not being taken by careless people. They are being taken by people who trust their doctors, who followed instructions, who are doing their sincere best to manage real conditions and real pain. The gap between that sincerity and the knowledge in this video is not a personal failing. It is a systemic one, a gap between what is known in nephrology and what reaches the people most affected by it. You now carry some of what I know, the mechanisms, the studies, the specific questions, and the understanding that the kidney function you have right now, whatever that number is worth protecting with the specificity and urgency that silent organs rarely inspire until it is too late. The best outcomes I have seen in decades of nephrology practice belong to patients who came in early, who asked the right questions, who understood that GFR is a number worth knowing before it changes dramatically, who advocated for themselves in exactly the way this video is equipping you to do. That is you. Now. Today. If this video gave you something real, a question to ask, a pill to discuss, a family member to share this with, please consider subscribing. Every week, I bring you this same level of honest, clinical, evidence-based guidance with nothing to sell and nothing to hide. Next week, I'm going to share the 5 morning habits that nephrology research shows can measurably protect kidney function and slow GFR decline. Habits that cost nothing, require no prescription, and can begin tomorrow. Based on the same science that I use with my own patients every single day. You will want to be there for that one. Until then, know your GFR. Bring your complete medication list to every appointment. Ask the questions this video gave you. And remember, the kidneys filtering your blood right now have never asked for anything in return. It is time to give them the information and the advocacy they deserve.